Welcome again to another edition of the Osteopathic Lyceum podcast. What I'm going to attempt to do today is kind of take you on a bit of a walk through a bunch of concepts and show why this extends the point of me making in the past that flaws in the fundamentals. Now, I did this with the Traub-Herring-Meyer waves and cranial osteopathy to show how the flaws in the fundamentals are maintained. So the more assumptions you make on the base bedrock of a concept, the more that maintains and essentially reproduces the more you use that concept. So I've done this with Mitchell Mechanics, I've done this with Fryette to essentially let you know in the past that these models, while used consistently within the profession of osteopathy, really don't have the value that they're claimed to have or that one would want them to have. It's not that they're useless, it's that they are not valid. They are not what they say they are. And at best, they barely allow somebody to teach a novice about what to do. There's much easier ways to do it to just zoom out to a much more macro level. So one of the things that you'll see over and over again with some of the stuff that I point to here is that the concept of macro identifies micro, or large movements are made of smaller subcomponents within the human body, and that when the large movement is not working appropriately, the smaller subcomponent is usually identifiable with vision in most cases. And there is the reality that palpation allows you to identify resistance to motion, even in the presence of what would be considered appropriate full range, right? So palpation helps you find resistance to motion, even when appropriate full range is available. And vision usually allows you to better identify asymmetry of motion or lack of full motion. Okay, so I'm going to share my screen here. Hopefully this opens the way that I want, and I'll have to jiggle the screen a little bit here. Right, so change the size of my viewing window. Okay, and what we're going to begin looking at is a journal article about models. Okay, so I'm going to highlight this so that I can get back to it, and hopefully it does what I want. That's okay, that'll do. So the article is Models and Theoretical Frameworks for Osteopathic Care, a Critical View and Call for Updates and Research. This is by Georges Estevez, Rafael Zeguera-Parodi, Patrick Van Dunn, Francesco Ceratelli, and Paul Vaucher. So hopefully I didn't mess any of those names up because I'm making assumptions based on their origin. So hopefully my accent didn't really mess that up. And this is from March of 2020. So hopefully we can get back to where I was. Okay, so this paragraph is quite important because often it can seem as though I'm just providing my own viewpoint and that it's all me with respect to that viewpoint. Others, at least to some degree, share this viewpoint. So I'll read from the paper. There's an overall scientific consensus on the importance of having a robust theoretical framework for complex health interventions such as osteopathic care. Traditional or innovative theoretical models are more likely to be accepted and implemented if they provide guidance on the process of care, clearly frame their intent and level of application, are logically plausible and consistent, are backed up by a rational, documented understanding of the change process, including causal relationships among the constructs, are testable, are supported by empirical observations, show good explanatory power, and are generalizable to different settings and subpopulations. That is essentially a really long-winded way of saying that something essentially is matching Karl Popper's falsifiability concept. So something needs to be falsifiable. So the reason that that becomes important is with respect to, say, a hypothesis being a set of predictions that when tested in a way that would falsify those predictions, and you don't falsify those predictions, you gain confidence that it accurately explains how things work. And you need the evidence to do it, because the more that you go through that process, the more you attempt to falsify your predictions. That's the accumulation of evidence, of empirical evidence, that when it doesn't get falsified, you gain more and more confidence. So that's essentially Karl Popper's falsifiability concept, or Karl Popper being the person that most appropriately and earliest described that, right? So that's just a really long-winded way of saying that. Now, to go back into that, Unfortunately, in osteopathic education, taught models are largely depend on tradition and political priorities rather than scientific standards. An example of this is the 5 osteopathic models of care agreed upon by policymakers during the elaboration of the WHO report. I'm going to break out of the quote here. I've spoken about that. I did not come across this article at the point that I spoke about that. And I haven't read further in this, right? So, I mean, it would seem strange that I haven't read further in this, even though I'm recording on it. You would expect that I would have read this deeply before I comment. And at least in this case, I haven't. I kind of got to the point where I saw the most important thing, and I wanted to share that just for the purpose of showing that I'm mirrored in some way by others in my view that the models are not as useful as we would like them to be. The 5 osteopathic models, what I would claim, are simply just a lens to post hoc or after the fact kind of tell a story about what you found and relate them. So we'll see what they have to say here. The model sets 5 alternative views through which a patient's musculoskeletal condition can be evaluated, understood, and treated. The biomedical structural model, I think that might be biomechanical. Yeah, that should be biomechanical. Please excuse my small glitch in my system. The respiratory circulatory model, the metabolic nutritional model, the neurological model, and the behavioral psychosocial model. The overall model does not provide any testable components of any underlying theory. It does not, therefore, meet expected standards of a theoretical model on many points and is largely insufficient to justify the profession's identity in higher education programs. The 5 osteopathic models approach has nevertheless been broadly adopted nationally and institutionally by many countries and training institutions, arguably without the required level of critical analysis. Robust assessment, revision, and consensus of theoretical models in osteopathy are still lacking and require clearer views on what to expect from theoretical models. So in much fancier language, in a published setting, they've said what I said, me having not read this material prior to now. What that suggests isn't that my viewpoint is correct or that their viewpoint is correct. It suggests that the underlying concepts from which they are working and I am working are similar enough that we come to similar points. So again, it doesn't mean I'm correct, doesn't mean they're correct. It just means that we're likely working from a similar angle. The 5 models just don't do much aside from reinforce previous things in the profession. As they noted, there's really nothing testable. It's just a viewpoint. It doesn't really check out anything. It doesn't inform you as to how you would assess something. It just informs you as to how you could think about something. And when you look at Foundations of Osteopathic Medicine, it essentially says that. It doesn't say that this is exactly what's going on. This is a way to think about it and then behave. And it really doesn't tell you how to behave. It sort of does, but it sort of doesn't. Okay, so just as a starting point in me speaking today, that gives you some grounding that the models in the profession really are not models. And I've also made the claim that osteopathy doesn't really have any theories, right? Because a theory is a hypothesis that has been tested in a way that would falsify the hypothesis so many times that it has not been falsified, it has not fallen apart, it makes as few assumptions as possible, and then it can get to the level of being considered a theory because it accurately predicts reliability, or it accurately predicts reality in a variety of circumstances and doesn't fall apart. It doesn't dissolve. It doesn't get falsified, right? So osteopathy doesn't have theories. There's a lot of terms with theory. There's a lot of words that end in theory or concepts that end in theory. They're not theories in a technical sense, not even remotely. They're barely even hypotheses, right? So we'll look through some here. This relates very, very much to the respiratory circulatory model. There used to be, you would hear the 4 diaphragms, now you hear the five diaphragms. So the tentorium cerebelli, the tongue, the thoracic inlet, the respiratory diaphragm, and the pelvic floor. All right, you see that. Do I have this highlighted? And I probably don't. Yeah, realistically, it's what you see with this 5 diaphragm model or the 4 diaphragm model is there are sort of transverse planes of anatomy that sometimes are contractile, sometimes are not, sometimes are more voluntarily contractile and sometimes more reflexively contractile, right? It just depends on which particular one you're looking at, but it's just kind of, they go like this, and because they go like this, they allow for the orderly movement of nerves and fluid, that fluid lymphatic or blood, right? So you essentially have these kind of organizing points where stuff orderly passes through in an orderly fashion. And then what you think about is, hey, if there's some form of restriction in any of these, then I'm going to have a problem with nerve or fluid. And fair enough. But it wouldn't matter where it was if you have a restriction. So if that holds true conceptually, then what would hold true is wherever you have a restriction, wherever you have an alteration in pressure on a vessel or a nerve. So if you buy into mechanotransduction, if you buy into axonal transport or axoplasmic flow, if you buy into vasomotion, really is local autoregulation of blood flow, then that altered pressure environment would do it anywhere. So it doesn't matter where the restriction is. It matters that you can identify it and work on it. Putting the diaphragms as a hierarchy is instructive in a way that would allow you to miss the other restrictions. So if you restrict yourself to a respiratory circulatory model, you miss it, right? Because the restriction could be anywhere. But if you're only looking at the diaphragms and you think the diaphragms are the most important, then you'll miss stuff. So what ends up happening is if you use any of these models as higher in your hierarchy, then you'll miss the other stuff. Osteopathy, unfortunately, boils down to find what doesn't move and work on it, right? That's because osteopathy centrally believes that there is that there are mechanical correlates to health and disease states, to use the boiled down statement that I've made before. So wherever there's a restriction, it relates to health and disease states in some way, shape, or form. Now, I will say that it doesn't always do that, because there are times when you can see a restricted motion or increased pressure in a particular area, and the person that you're looking at or examining is okay, right? So it doesn't always relate appropriately. So where do we go? To look at something that is spoken about in some osteopathic circles or has been influenced by osteopathy to some degree, we can look at something called Sacro-Occipital Technique. So you've heard of craniosacral therapy. Then you can look at Sacro-Occipital Technique. So craniosacral is John Upledger, who was a DO, who was involved in surgery, whereas Dejarnette was apparently a DO and a DC. I did not know that he was a DO. There we go. I learned on the fly. I didn't know he was a DO. So he was a DO and a DC. So sacral-occipital technique, some people would talk a little bit more in the chiropractic world, but because he has a certification as a DO in some way, shape, or form, you can talk about it that way. If we look at it, generally, there's a spot down here. He used a lot of wedges, apparently. So he would basically look at the vertebral column and restrictions there and find blockages and talk about, the base and the top, right? Or the top and the base, however you want to look at it. So the occiput and the sacrum. And he would work through there and in varying areas. So he didn't necessarily restrict his treatment specifically to the top and the bottom, the sacrum or the occiput. He would work through the rest of the area. He was adjusting vertebral segments affecting the musculoskeletal system through wedges or blocks. So developed the use of pelvic blocks to affect pelvic and whole body distortions in extremely non-traumatic matter. He also built a series of treatments using blocks or wedges to affect the patient by utilizing gravity as a slow force of correction. SOT orthopedic block placements can be applied under the rib cage, clavicle, lumbars, thoracics, knees, and in various directional positions. Very broadly from that, what you can gather is that wherever he identified a restriction, or he would have some related method to block and leave somebody relatively still with that wedge there and let time do it. So the person would just be sitting relatively still or laying relatively still with a wedge in a particular place, and they would breathe. He may be doing something else, but the wedging and waiting would do a lot of it, right? But what you can see with sacro-occipital technique is he wasn't necessarily localizing it to the cranium or the sacrum. He would wedge wherever. He would also work through the vertebral column. So the one that I actually want to look at really quick here, because it highlights an assumption, So you remember, when you're looking at a hypothesis turning into a theory, you want as few assumptions as possible. If I note that the flaws in the fundamentals are a problem, then I can point to this here. This is affecting the cranial bone dynamics. There are various systems of cranial bone manipulation, the majority of which are philosophically based on Dr. William Gardner Sutherland osteopathic cranial techniques. Dejarnette studied under Sutherland, so Sutherland's osteopathic cranial techniques create the basis for SOT cranial technique. SOT cranial techniques have indicators that fit into a framework of care, which relate to the SOT category diagnosis of the body. Therefore, SOT cranial techniques have a specific place and are used to enhance craniospinal and meningeal dynamics, cranial sutural mobility, blah, blah, blah. The thing to point back to is the assumption that what Sutherland said is a good foundation. So the flaws in Sutherland's stuff that we've talked about previously will be present to some degree within SOT or Dejarnette on account of the fact that the fundamental flaws were not questioned and were accepted. There's something here as well, just above, effect on the myofascial system of the body. The myofascia, soft tissue, affects and is affected by the vertebrae, ribs, extremities, viscera, and cranium. Well, if they're all connected in the same person, no duh, right? The simplest place to go is find the restriction. Don't worry so much about the specific structure. Find the restriction, because you have that external environment of observation, which means that it is much more difficult to accurately identify which structure or structures are the problem. You can identify the problem with movement. That then relates well to macro identifies micro. Large motions are often made of smaller, or are essentially in humans always made of smaller subcomponents. And when the large movement isn't working properly, the smaller subcomponent is identifiable. So instead of worrying as much about the specific structure, find the movement problem, deal with the movement problem. You'll be accurate to what you found in claim and in treatment. Right. Now we'll move on. There is another model that's sort of come in. A lot of this comes from, I guess, applied kinesiology. It may not be perfectly from applied kinesiology, but it's like, dynamic neuromuscular assessment. Which is based on the 5 primary kinetic change. Those are based, and this is from this page that you can see, are based on the theorem of Andreev-Leeming's core subsystems and how those subsystems connect to the entire fascial fabric through the kinetic chains. Each chart, and this is just trying to sell the charts, and I'll move forward in a moment here, outlines a primary physiological principle in movement. Bones, joints, ligaments, tendons, muscles, fascia do not work in isolation. They work synergistically to create movement. When movement is balanced and efficient, the players are all cooperating. That's not testable, right? That's just a no-duh statement. You can't test that. It's not possible to disprove that. There is no human that moves in isolation. There is no muscle that moves in isolation. If a muscle manages to contract appropriately, then that neurological signal had to get through a lot of distance, right? So let's just say there was some problem somewhere on the nerve, then maybe the signal wouldn't flow. This is not a testable concept. It's a no-duh concept, right? It is not philosophically sophisticated. It's no duh. Okay, so to move forward with this dynamic neuromuscular assessment concept, there is a set of blogs, white paper, anatomy, kinesiology. Yeah, so just look at this title, Anatomy and Kinesiology, Moving Beyond the Obvious to the Profound. Just the title alone, while possibly, I don't know, aspirational, that's tough, right? A lot of the stuff that people talk about with kinetic chains or fascial chains really depends on how somebody dissects. So the classic standard dissections, you will definitely cut through a bunch of fascia. So when you dissect in a slightly different way, it looks intact. But those are not appropriate representations of how that system functions in the living human. Even that statement from me is not philosophically sophisticated. It's just like, yeah, it's different. So what? Which is why in that living person who you're going to work with, I say find the movement problem, work on the movement problem. You'll be accurate to what you found, right? The claim will be accurate to what was identified, and the treatment will be accurate to what was identified. And if it changes, you'll have a really good understanding. The subcomponents you'll understand less because they're more obscure because you're working in that external environment of observation, right? blah, 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 putting the dynamic and dynamic neuromuscular assessment. So one of the things that they do talk about a lot about is the respiratory diaphragm. While manual muscle testing can be a powerful tool, movement is infinitely variable because manual muscle testing attempts to put movement into a confined box with fixed positions. It has its limitations. I have a problem with classical conventions that say this movement is XYZ muscles. Muscles do not work in isolation. Muscles work synergistically with bones, ligaments, bones, joints, ligaments, tendons, muscle, fascia, and skin. We can isolate movement. We cannot isolate structure. So that resonates actually fairly well with what I'm saying, especially from that external environment of observation. So philosophically, the position is, well, it's all connected. Well, of course it's all connected. No doubt. Where's the problem? The idea that if you put the body in a specific position, you are testing XYZ muscle is limiting. Some 15 plus years ago, I was seeing a physical therapist for my shoulder injury. I don't necessarily need to go through that. There is a statement down here that is very interesting. Movement has three components of players. One side of the tissues are in concentric contraction, so shortening, this is the work production phase. The other side are the tissues that are lengthening. This is the eccentric phase of the movement. This is often referred to as the deceleration phase of movement. The third aspect of movement are the stabilizers that provide support for the movement. This is analogous to isometric movement through its dynamic, and though it is dynamic in its application. So that sort of will map, well, it does map well. It just might, it's sort of convoluted in how it gets there. That maps well to the heuristic that I utilize is macro identifies micro. Those larger movements will show where the smaller problems are. So if a large movement is predicted to be free, and when it is not free, you can then use your eyes to see where the problem is, right? So if you do essentially shoulder abduction, you bring the arm up like this, right? If the arm only goes to here, right, then something below those eccentric muscles, those muscles that are lengthening below the scapula or below the, sorry, or, you know, say below the clavicle as a reference point. It's not perfect, but some of the rotator cuff muscles that would not allow the humerus to move away from the scapula or the lat, right? Something below would be holding it down. Whereas if it gets all the way up, but it's forwards, right? It's pulled forwards when you try to keep it down or in line in the coronal plane, then you have to begin to believe that it's something in the front pulling it forwards, right? So you could think about pec or pec minor. That maps reasonably well to that eccentric thing. So the eccentric thing is really quick. If you can't get it up at all, then maybe you think something is majorly different or super tight everywhere within the joint. So maybe in the case of the shoulder, you have identified to some degree what seems like either a rotator cuff tear or frozen shoulder, adhesive capsulitis, right? But you can see that there's a lot of assumptions in the model. The assumptions that the fascial systems work in a particular way, that this works in a particular way, right? So it can probably drive behavior okay. There's probably lots of success stories with this model, but it's not unique because there's a lot of other models that have success stories, right? Let me move this for a second. If we speak to something more classically within the osteopathic realm, the common compensatory pattern, its origin and relationship to the postural model. This is Zink, right? Or this is Ross E. Pope, D-O-F-A-A-O, speaking about Dr. Zink, J. Gordon Zink. So just very basic grounding, which is visible here. J. Gordon Zink, D.O., was the originator of the term common compensatory pattern, CCP. He used the term to describe commonly found patterns of dysfunction in the body, the neuromyofascial skeletal unit as a whole. Several other physicians before and after, or before and since, have also described recurring patterns of dysfunction found in their patient populations. So right there, recurring patterns in their patient population, not the patient population, not the population at large. They're giving it to you from their own perspective. So if they happen to be in a region that has people who are very similarly occupied through the day with their repetitive tasks, then you would suspect that you would see very, very similar things. So you could think that that pattern is the norm, whereas it's at least possible, depending on where you are and where your patient population comes from, because patient populations come to practitioners in different ways for different reasons. So you might get a lot of pregnant patients. You might get a lot of motor vehicle accident patients for some reason. That's not necessarily indicative of the population at large. It's just you see these types of people. So you can be skewed in your view of what's common just because you happen to be accessing a particular patient population more than others, or the region in which you live, the people are occupied similarly, consistently, with similar habits. So that's a problem right there. Just because Zink saw it doesn't mean it's the pattern. It's just the pattern Zink saw. And most of the compensation, I believe Zink claimed, was in the fascia. We're not going to get too deep into this, but it was just, this thing at this area in the transitional zone, the fascia goes this way, and at this transitional zone, the fascia goes that way. So you're thinking about where the cervical and thoracic columns unite, where the thoracic and lumbar columns unite, and then the lumbosacral, where they unite, they're called transition zones by many, and the fascia will switch one to the other to compensate, right? So something to note here, the origin, right? Anyways, the origin of the common compensatory pattern. Figure 3 shows a brief overview of the development of erect posture. We know that as the embryo is enfolded in the womb, its back describes a C curve. Strange writing. It is not one continuous curve, but rather a series of bent segments that intersect at what will become the transitional junctions. The child attains upright posture first through the development of an anterior cervical convexity and then an anterior lumbar convexity. Zink believed that the lumbar spine of the growing child was especially vulnerable to repeated minor traumas that result in twisting of the torso. He also felt that the ideal physiologic pattern was best suited for locomotion, and that while the CCP was efficient a pattern, it was very adaptive. So the common compensatory pattern that Zink saw, he thought was adaptive. But what you've already seen there is Zink thought that there were a lot of things going on with the development of the lumbar column in children. He thought that. He didn't test it in a falsifiable way. He just thought that and then developed above it. So he made an assumption and he built on top of it. So if there's any flaw in his assumption, or his assumption could be correct, but if there's any flaw in his assumption, then everything he built on top of it continues to carry that flaw, which is a major problem. So this relates well to the first thing that we pointed out from 2020 with Estevez, that most of these models are taught just because of tradition and politics, not because they're testable or accurate. Other models like this would be three triangles and unities, the Myogon model. Now, there's more than one Myogon model. There's like the Institute of Classical Osteopathy Myogon model, which is really Henry's line. So that's an American DO. He basically just drew points on the foramen magnum, 4 points, and then he drew straight lines to intersect, which happened, at least when he drew them, to intersect at, God damn it, fourth thoracic vertebrae, I think, is where they tended to intersect. So the Institute of Classical Osteopathy thinks that's very important because of Henry's lines. And then they hit the sacrum, right? So you have to draw them with those points. So you actually have to make the points of the foramen magnum. And then what you have to do, is it 40 or 90? Fourth thoracic or ninth thoracic? I don't remember, but yeah. Anyways, you draw the four at the foramen magnum and you draw 4 points on the sacrum, and you just connect the lines and they happen to intersect there. So that's not even mathematically or physically reasonable. It's just I chose to draw 4 dots, and then 4 dots on the top, 4 dots on the bottom, and then intersect the lines. So you've got that model, and that model tends to be more of a sagittal model. And then you have the Canadian Academy of Osteopathy Myogon model, which is more of a coronal model, and it is described through the choice of specific muscles that happen to look like triangles. The subclavius muscle is considered part of the upper baseline because it's under the clavicle. Portions of the trapezius, and then getting down to T12. So T12 becomes a more important point in the Canadian Academy of Osteopathy Myogon model. The pectoralis minor is more important than the pectoralis major in that model. The quadratus lumborum and the psoas or the iliopsoas, despite not having much evidence that they mobilize the lumbar column, are very important in that model. The QL sort of stabilizes, the psoas definitely stabilizes the lumbar column, but doesn't necessarily generate movement insofar as most of the literature that's available. Where is it? Do I have this up here? I think I have this up here. Chapman's reflexes is another kind of traditional model. So let's just say we look at those Myogon models. They allow you to describe some findings, but they don't necessarily line up with what you have actually found as accurately as you'd like, because they make you make assumptions about them, because they're based on assumptions. It's not that they have no use, it's that they're less accurate than they could be. So if you have either of those Myogon models as the top of your hierarchy, then you will build your descriptions based on that, which means that it's easy to miss things that don't fall well into that model. You can really mail it in with a Myogon model. If we look at something more traditional, so we look at, again, instead of Zink, we look at Chapman's reflexes. Here. Where are we? So this is a paper, this is a paper that's contained within StatPearls, which is run through PubMed. This is by Megan Bath, Amanda Nguyen, and Bruno Bordoni. The intimate connection between the nervous system and the lymphatic system in both health and disease has long been acknowledged in osteopathic medicine. In fact, treatments such as rib raising and occipital inhibition have as their foundation this very principle. Doesn't mean it's right, it's just the principle. Though first described as neurolymphatic points by Frank Chapman DO in the early 1900s, Chapman's points are now defined as organ-specific ganglioniform contractions associated with underlying visceral dysfunction. More specifically, Chapman's points present as smooth and discretely palpable nodules located deep within the fascia in regions related by dermatome to the dysfunctional viscera. These points are sharp, pinpoint, non-radiating, and anatomically consistent between individuals. Okay, so you can see that you have to buy that you can accurately identify this thing deep in fascia. Maybe you can, maybe you can't, maybe you buy it, maybe you don't. But if that's an assumption, that is not something that's been tested. That's just the standard claim within Chapman's reflex system. So issues of concern. This is important. The issue of great concern to the osteopathic community is the minimal collection of peer-reviewed clinical research regarding the physiology and presence of Chapman's points. Currently, much of the information about Chapman's points are anecdotal and based heavily on the clinical observations of a limited number of physicians. As of yet, there is no evidence confirming the presence of Chapman's points in tissue biopsies, but there exists a few studies demonstrating that sympathetic and endocrine alterations occur after rotatory manipulation. Just twist your finger around it. Sorry, I think it's more like this. Rotatory manipulation of Chapman's points. The findings of these studies support the hypothesized physiology and presence of Chapman's points, as will be explained in further in successive sections. So they at least note that these are not things that can be found on tissue assay. However, there is evidence that what you get is when the practitioner claims they find it and they circle it, that you can note some physiological and endocrine changes. I don't know those studies well. I don't know if they had a control condition where if you did the rotatory motion on a non-Chapman's point, that you got similar changes. Because if you did, then there's nothing there. I do not know that, but it is easily testable, right? So so you have the opportunity to falsify this. So I don't know if it was done, but I do know that it's falsifiable. So if I look and I find that they didn't have a control condition where they would do it on a non-Chapman's point and compare and contrast the results, then it becomes moot, right? So if I look and I find that and there's a difference, then there's something to buy. If I look and I find that and there's no difference, then there's nothing to buy, right? Yeah, that's decent enough here. So essentially everything else that would be written in that would let you know the standard within Chapman's reflex points. It would fall into one of those models that is taught by tradition, not necessarily by evidence. It is testable, so that's actually nice. This is one of the models that's testable, even though it probably hasn't had the best testing, or the testing that has been done has not suggested that it is what it says that it is. There is evidence that says when you do those rotatory motions on a claimed Chapman's reflex point, that you have some physiological change. I need, as I already noted, I need to look at that research to better understand it. But what it does is it kind of relates again to these models making fundamental assumptions that have flaws, and then everything that's built upon it continues to contain those flaws, such that when you test it in a way that would deal with those flaws, that the models don't hold up, which is why I say osteopathy doesn't have any theories. It has hypotheses that have essentially all been disproven or falsified. So again, we go through all these models over and over, and we find the same thing, that they are not valid. It doesn't mean that the behavior that comes out of them when used for teaching is not valid, because you do often have very good, consistent ranges of patient outcomes that are generally positive, but the claims just don't hold up. So the problem that you run into with most of these models is that, again, they're codified within the profession, but they're not what they say they are. So continuing to use them doesn't help the profession move forward. It helps the profession reinforce things that's already said. I think osteopathy is fantastic. That's why I'm a practitioner. But I think we can do better with ease if we understand science better, the philosophy of science as an absolute minimum, and then we go forward and we do more work in a testable way, or in a way that would allow, or test in a way that would falsify our hypotheses. And to be fair, I think a decent amount of that work's been done, and most of the hypotheses have been falsified. It's just there's a lot of people in the profession, within the profession, that don't like it. So hopefully that was a useful kind of jog around osteopathy and some of the models and some of the concepts, and allows you to better understand why I suggest that if you come back to macro identifies micro, or large movements are made of smaller subcomponents, and when the large movement isn't working appropriately, you can often identify where it is with your eyes, that's a really easy place to assess from, treat from, and make accurate claims from, versus saying it's this fascial chain, it's this particular fascia because the movement is restricted here. It's definitely this structure. It's like, yeah, well, people are built a little bit different. Their pennation angles are a little bit different. Your pennation angle on one side of on your right bicep and on your left bicep might be different. Your bones are different. We're asymmetrical enough that we can't make these assumptions. So there's a lot of anatomy that is asymmetrical and inconsistent even within an individual. So if you stay with the movement problem, you have accurate assessments, accurate claims, and accurate treatments, right? And then the concept that if there's an assumption or a flaw in your fundamental, anything you build on top of it will continue to contain that flaw. That is unfortunately consistent through almost everything I've seen as a model in osteopathy. So you can continue to use them if you like. However, if you've gone through this and heard me talk and seen what I'm showing you, you are going to have a hard time continuing to claim that what you're saying is valid. So again, hopefully that was useful, and we'll talk again soon.